Good morning, everybody. Welcome to PACS 2018. PACS is a conference which is for pulmonologists who are interested in allergy, sleep, asthma, and interventional pulmonology. And today we have Dr. Felix Herth with us, who's come all the way from Heidelberg, Germany. His areas of interest are interventional pulmonology, and we are going to have a few questions for him. These are for the benefit of all the pulmonologists who could not be here today for this conference. Professor Herth, one small question for you is, we have a lot of severe asthmatics in India, and there are new technologies available to treat them beyond medical therapy. So one of the new things that has come into India is bronchial thermoplasty, and we would like to let our audience know how would we select patients for this procedure.
Yeah, thanks a lot for that question. I think thermoplasty is a new option for patients suffering on severe asthma. And when you look for those patients, you should be sure that the patient is adherent to the therapy, to the inhaler therapy. And then we're looking to the biomarkers. When you have an elevated IgE, it's maybe a candidate for omalizumab. When we in Europe have access to the IL-5 antibody, when the eosinophilic measurements are high, this is maybe a candidate for one of the newer antibodies against the IL-5 or the IL-5 receptor. But in those patients we're calling at the moment neutrophilic or Th2 low, thermoplasty is for sure an option where we have shown in a lot of randomized controlled data that the patient is benefiting a lot, especially regarding quality of life, the need of seeing a doctor acutely or even hospital visits. We really can reduce them when we selecting the patient in the best way. But even on the other way, from the other view, when we have patients who have been on omalizumab or have been on one of the IL-5 antibodies and did not show any response, even that is then a subgroup where we can try the thermoplasty.
Thank you. My next question would be, are there any specific lung function criteria that we would look at when we are selecting patients, and what would be more important, the lung functions or the clinical parameters?
Yeah, these are also questions which we changed our mind over the time. Initially, in the initial trial work, we only enrolled patients having an FEV1 above 60%, but now in the registries, it's clearly shown that it works as well in patients who have an FEV1 lower than 60%, so we're doing it also in patients who have an FEV1 close to 30%, because when the patient is really fulfilling the criteria of severe asthma and you do not have any more options, you can help them really with the thermoplasty. Regarding the outcome, for sure you will see some changes in the FEV1, but for me, treating a severe asthma patient, all endpoints which are patient-related, so emergency visits, hospitalization, doing what you want, no need for emergency medication or rescue medication is way more important. So we're focusing in the registries more on the patient-related outcomes endpoints, and we're seeing that we can improve them. So in the daily doing, patient-related measurements are more important for me than lung function measurements.
What precautions should you be taking before you subject patients to bronchial thermoplasty?
Yeah, there are a couple of there are contraindications. You see, we're doing a radiofrequency ablation. That means we're delivering thermal heat, and if the patient have a defibrillator implanted or have a pacemaker, you cannot use that. You interact and damage maybe the implant, so this is a no-go, but luckily we do not have a lot of those. And then we should not treat the patient when he has an acute exacerbation. The patient should be stable in his disease for more than 3 months, and then we're putting the patient at the day of the procedure for 5 days on oral corticosteroids to prevent the so-called bronchoscopy-induced exacerbation. So an exacerbation which is driven by the bronchoscopy, not by the thermoplasty, but by the procedure itself, putting a scope in such a patient. So therefore, we have the patient 5 days on corticosteroids, and by that, we really can prevent any severe side effects.
What would be your usual treatment duration for bronchial thermoplasty? How many cycles, and just for people who are new to this technique, how many cycles of treatment, and when would we start expecting lung function and symptomatic improvement?
So at the moment, thermoplasty is offered in 3 sessions: right lower, first sessions, 4-6 weeks later, left lower, and another 4-6 weeks later, the upper lobes together. And normally we seeing the patient for a bigger check-up 3 months after the last procedure, and by that we really can, at that time we really see changings. But as mentioned before, lung function in the daily doing is not that we're looking for the lung function, but we're looking more for the patient-related outcomes.
I think we've got a fair idea from Professor Felix about what would be the patients that we would select for this procedure, as well as what precautions, what clinical response we should be looking at. I thank Professor Felix for being with us here today, and I hope this video will benefit you all for the future procedures. And if you all have any questions, I'm sure you all can come back and check with PACS 2018 and Dr. Deepak Talwar and his team. Thank you.